Добрий день всім. Чи Thuy Mai мене чує? Добре.
Yes, I can hear you.
Добре. Добрий день всім. Дякуємо, що ви доєднались до нашого вебінару. І я дуже рада вам представити доктора Thuy Mai Luu, педіатриню, директорку канадської мережі спостереження за новонародженими Canadian Neonatal Follow-up Network. І ваші питання, як зазвичай, будуть в кінці. Я буду їх зачитувати, перекладачі будуть їх перекладати і будемо на них відповідати. А поки що прям вже розпочинаємо і прошу доктора Thuy Mai Luu до слова.
Hi, everybody. Greetings from Montreal in Canada. Here it's the morning, but I guess for you it's good afternoon. So I'm a pediatrician at the Université of Montreal. I'm also the director of the Canadian Neonatal Follow-up Network. And a lot of the attention is often on neurodevelopmental outcomes of children born very preterm. But this time I will turn to long-term physical health of adults born preterm. So as many of you know, 1 out of 10 babies is born preterm before 37 weeks of gestation. If we look at those born very preterm, below 32 weeks, that's about 1.5% of babies. With improved medical care, especially in obstetrics and in neonatology, survival following preterm birth is increasing. These are some data from the Canadian Neonatal Network. And in countries, for example, in Canada, Europe, above 90% of children born at 28 weeks and above now survive. And for children in middle-income countries, it's about 50 to 70%. And once they survive neonatology, majority will go into adulthood. And we know that a lot of changes happened around the 1990s with antenatal steroids given to mothers, surfactant, and better respiratory support. So when we think about it, this is when survival really increased in neonatology. So the first generation of survivors of modern neonatology are now entering their 30s and 40s. So today, my objective is to provide an overview of the multiple health impacts of premature birth with a particular focus on the development of cardiovascular disease in adulthood. I'd like also to identify risk and protective factors for optimal health. And we'll examine how interventions throughout the lifespan can improve health. The main message I want you to keep in mind is although preterm birth is associated with a higher vulnerability for chronic health condition, its effects can be mitigated through preventative measures. But this requires better screening for risk factors, for example, hypertension and glucose intolerance, so we can intervene early, and also advocacy for healthy lifestyle habits. And I hope that throughout my presentation, you can get this message and think about screening for these other health conditions when you see a child or adult born preterm. So now I'll go with some basics. So one thing which is important to remember is the third trimester is a critical period of development. And I said I would not be talking about the brain, but I guess this picture can illustrate my message and then we'll apply it for other organs. What you're seeing here is the brain of a newborn baby at 25 weeks and the same baby throughout the third trimester. And you can see that from the 25th weeks and 39 weeks, a lot of things are happening to the brain. There is growth and lots of maturation. And you can imagine that if you have a baby who is in utero, in the mother's womb, well protected in a healthy environment, the brain will develop differently than if you have a baby who is in the NICU and exposed to a lot of adverse conditions. It could be pain, it could be infection, and this will certainly affect the brain. But this is the same for other organs. When the baby is born preterm, anywhere between 22, 23 weeks to 37 weeks, several organs are undergoing growth and maturation. We've talked about the brain, but the bones are also undergoing mineralization. The lung is developing. There is maturation of the hypothalamic pituitary adrenal axis. There's development of the vascular tree and cardiomyocyte proliferation, and the kidney is developing also. But instead of being in a secure environment, the baby may be exposed to sepsis, lung injury, malnutrition, too much oxygen or not enough oxygen, steroids. In brief, all those interventions are necessary to keep the baby alive or are associated with prematurity, but they can affect how these organs will develop. And that can lead to alteration in the organ development, which can later on affect function. That brings me to the developmental origins of health and disease, and I think that's important for you to understand my talk. So in the DOHAD hypothesis, which was brought by Professor David Barker, chronic non-communicable health disease, such as hypertension, diabetes, or asthma, may be determined not only by lifestyle habits, but also by early conditions, including in utero. So any disturbances in this early life environment, and preterm birth would be one of these disturbances, may affect long-term health. And there are two mechanisms with preterm birth that could disturb the organ development. One is maladaptation, which means that the organ needs to have immediate adaptive changes to the intra or extrauterine environment, which are necessary to survival. But over the long term, this may not be good for health. For example, let's say a baby is exposed to malnutrition and has intrauterine or extrauterine growth restriction. What will happen is that the baby will try to save all the energy, all the calorie to be very efficient. But once they're not in the environment of malnutrition, if the baby is exposed to lots of food, lots of calories, they will still be in the mode of saving this energy. So that can lead to abdominal obesity, for example. The second mechanism can be direct lesion. For example, barotrauma or oxidative stress due to the lung during ventilation could bring a direct lesion to the lung and interrupt alveolar and pulmonary vascular development. So maladaptation and direct lesion are two mechanisms that can make the organ develop not necessarily normally and affect function over the long term. To understand this better, in Montreal, we conducted a study called the Health of Adults Born Preterm Investigation. That was an observational cohort study, and we recruited 101 young adults born at 29 weeks of gestational age in the province of Quebec, which is a province in Canada, and they were born between 1987 and 1996, really around this area where antenatal steroids, surfactant, and better ventilation arrived. They were matched to 105 full-term controls. They were matched on sex, age, and reported race and educational level, so we could kind of control for social environmental factors. They were recruited among friends and siblings. And what we did was to have them come back at 18 to 29 years for a full health assessment. And what you see in the pictures are some of the participants that came to our study. So you can see that there was an adult born preterm who came with a friend or family born term. And most of the time, they kind of looked the same. So what was interesting, if one was smoking very often, the other was smoking. If one was very doing a lot of sports, often the friend was doing a lot of sport also. So that was good to control for the environment. So what they did over a one-day assessment was many examinations. So they had questionnaires so we could learn about their lifestyle habits, past medical history, family history, medication use. We also measured their weight, height, also blood pressure. We took blood and urine tests to measure oral glucose, lipid panel. We also did cardiovascular assessment, pulmonary function tests, exercise testing, a DEXA scan, renal ultrasound, and they left with a 24-hour ambulatory blood pressure monitoring. These adults were very amazing. This was a lot of testing, but what was very nice was that they said that they wanted to give back to research because the reason they were alive was because of all the novelties in medicine. So it was a way for them to give back to science because science kind of helped them survive. So these are some of the characteristics of our patient. So about 40-45% were male. Majority were white. This was our population in Quebec. The median gestational age for the preterm babies was 27 weeks with a mean birth weight of 920 grams. And interestingly, for the preterm cohort, 29% were born from a pregnancy which was complicated by hypertensive disorder, compared to 10% in the term control group. We saw them at a median age of 23 years. As you can see, the adults born preterm were in general shorter and also smaller in terms of weight. We were shocked to see that almost a quarter were using tobacco. That was pretty high, maybe a little bit higher than the Canadian population. However, we did not see more obesity in our preterm group. So what were some of our findings? So we saw that there was a higher prevalence of cardiovascular disease risk factors in adults born preterm. In terms of hypertension, 39% of the preterm group compared to 18% in the term group had hypertension. 31% versus 16% had glucose intolerance, and 40% compared to 16% had airflow limitation. And you just have to keep in mind that those are young adults who are just in their 20s. We wanted to compare the risk of disease. So we can see that the risk of hypertension, glucose intolerance, abdominal obesity, and airflow limitation was 2 to 3 times higher in the preterm group. And that's after adjusting for sex, age, and tobacco use. We also saw that there was an increased burden of cardiovascular disease risk factors in young adults born preterm. So if I walk you through the figure, you can see that in green, it's the term group. In blue, it's the preterm group. On the x-axis, it's the number of markers of chronic disease. So we look for hypertension, glucose intolerance, airflow limitation, and adiposity. And on the y-axis, you have the proportion of participants who had these conditions. So we can see that if we look at 0 marker of chronic condition, there are more term than preterm. But if we look at 2, 3, or 4 conditions, you have more preterm than term in general. Actually, for the number of chronic condition of 2 and above, 38% of adults had 2 or more conditions versus 22%, which meant an increased risk of 3.4 for the preterm group. So in brief, adults born preterm not only had higher risk of hypertension or glucose intolerance, but they also had more comorbidities. So one of the first conclusions from our study was that in general, in young adulthood, very preterm birth is associated with higher systolic blood pressure, higher diastolic blood pressure, higher rates of glucose intolerance, They also had more airflow limitation and also decreased bone mineral density at the femoral neck. However, in our cohort, we did not find any differences in the rates of hypercholesterolemia or the metabolic syndrome. The second thing that we wanted people to remember was that majority of young adults born preterm had normal results. However, when we were comparing to full-term controls, there were significant differences. For example, if we talk about blood pressure, I did say that 39% had higher blood pressure, which still means that 60% had normal blood pressure, which is reassuring. But when we compare the whole group, it's still a 5 millimeter of mercury of difference in systolic blood pressure. So we can say that 5 millimeter of mercury, maybe that's not that of a big deal, but at the population, that's important because studies have shown that if we look at the population level, a reduction in 4 millimeter of mercury of blood pressure is associated with a 20% decreased risk in stroke mortality and also a 15% reduction in other vascular disease mortality. So it's really important to really consider that. The other thing which is important to think is those adults were in their 20s, which is the peak of physiological function. So if I look at the lungs, for example, so what you see on the graph on the x-axis is age in years, and the vertical line represents the 20s, and this is really the peak of function. And what happened after the 20s, everything is just decreasing. So I'm sorry, guys, if you're above 20 and 30, we are just at this moment decreasing in our function, and that's just natural aging. But what with the preterm population, what happened is that probably that they attain a lower level, which would be the lower curve. And then what can be expected is afterward, there will be a natural decrease, and maybe they will reach symptomatic disease at an earlier stage just because they achieve a lower peak of function. And what you see in the dotted line is if you have additional hits, for example, smoking, maybe that will accelerate even more the decline in lung function. So this is an example with the lungs, but there is the same thing with the bone. The dark line would be the peak in the 2030s and then the normal decrease. And then what we could assume is that with preterm birth, the dotted line, they attain a lower peak, and then afterward, when it will decrease, they will have risk for osteoporosis that will come much earlier than for someone who is born at term. Now I will turn to some potential mechanism for increased cardiovascular disease, and I will focus on kidney development and heart development. So in our study, what we looked at was renal health. And we did see that the adults born preterm had in general lower kidney volumes, and kidney volumes were associated with higher blood pressure. And we know how important the kidney is for blood pressure regulation. So maybe this is one of the mechanisms. We also saw that in general, their estimated glomerular filtration rate, which is a proxy measure for renal function, was reduced in the preterm group. And there was also more proteins in the urine, which is another marker of renal dysfunction. So in general, in adult born preterm, there are also mild signs of reduced renal function following very preterm birth. That could also be a mechanism linking to cardiovascular disease. I'm also showing some findings, not just from us, but also from other researchers, which is showing changes in cardiac structure and function, which may be associated with later cardiovascular disease. In general, when we look at the heart through MRI or ultrasound, there is reduced size of the left and the right ventricle from birth to young adulthood. There is also a reduction in the diastolic function of the left ventricle that gets worse with time. There's also reduced function of the right ventricle and also increased left ventricular hypertrophy from childhood to young adulthood. And these are some findings from Adam Lewandowski from the Oxford group, which really showed that the young adults born preterm have altered left ventricular shape. Lewandowski also showed that if we expose the preterm heart to a second hit, this may also have a different response. So what they did in this study, so what you can see here is in red, it's the ventricular function of the preterm adults, and in blue, it's the function of the left, of the term adults. On the x-axis is the adults who's doing some exercise at 40% of their maximal capacity, 60% and 80%. And what we can see is at rest, there's no difference in ventricular function, but when they're starting to exercise at 40%, 60% or 80%, the heart of the preterm adult is really functioning less well. So preterm born young adults had, in this study, impaired left ventricular response to physiological stress, which could suggest a reduced myocardial functional reserve. So what are the implications? These are a series of studies that have been published by Casey Crum from Sweden. And what Dr. Crum has been doing, he has been looking at all data from a Swedish registry, looking at the entire population. So what they basically did was to look at over 4 million individuals that they track over 40 years of age. And the goal was to provide population-based estimate for mortality up to mid-adulthood for different gestational age group. And you can see the different age group from extremely preterm in red to full term in black. And so in general, during adulthood, mortality was 69 to 80 deaths per 100 person years. For the full term, it was 47 to 59 deaths per 100 person years. And if we look by gestational age, what we can see is in general, there was a 1.28-fold increase in all-cause mortality between 30 and 45 years, and this risk is increasing with lower gestational age. In this study, they also controlled for socioeconomic status and genetic factors, and the effect was still persisting. Mortality was driven by respiratory and endocrine disorders at later age. What he also shown with the same cohort was to look at the risk of ischemic heart disease in adulthood, and he did show an increase in 1.5 risk following preterm birth. They also look at stroke risk in adulthood, which was increased by 1.26 following preterm birth, and that was even more pronounced for those born at 27 to 32 weeks. If we look at hypertension, after adjusting for other perinatal and maternal factors, the risk of hypertension increased by 1.2-fold in adults born preterm before 37 weeks, and by 1.8-fold in extremely preterms. And this persisted from childhood to adulthood. In this study, they did not find any difference between women and men. And some of the effects were explained by shared genetic or environmental factors in the families. For example, if the parents had hypertension, we know that mothers who have hypertension during pregnancy are more likely to deliver preterm prematurely. So it's possible that there are some of the effect which is explained by family factors, but yet even after adjusting, there is still an effect of preterm birth. What about other cardiovascular risk factor following preterm birth? The risk of type 2 diabetes is also increased. Interestingly, the risk of type 1 diabetes is also increased. We're not too sure why this is happening exactly. And in Crum studies, he found also increased risk of dyslipidemia, which in our cohort in Canada, we did not find, but it might be because it's a different population. One thing which is also important to realize is we can talk about hypertension, diabetes later in life, but there are also implications for women who are born preterm when they will deliver. So we often say that pregnancy is like a window to what will happen to the woman later in her life in terms of her health. And this was a study actually conducted in Canada, and it looked at women born preterm and compared to a woman born at term, and they looked at their risk of pregnancy complication, namely preeclampsia, gestational hypertension, and gestational diabetes. And what you can see here, so in a dark blue, you have a woman born before 32 weeks. In light blue, you have those born between 32 and 36 weeks. And in white, it's the woman born at term. And there's a higher risk of gestational diabetes, gestational hypertension, and preeclampsia or eclampsia. And if we look at the proportion of very preterm women who had at least one pregnancy complication, that was up to 20%. So that has real implication for pregnancy follow-up for women born preterm. And how about other chronic condition? Once again, these are the studies from the Swedish registry. The probability of using asthma medication between 25 to 35 years is 2 to 0.4 times higher in preterm born individuals. And the risk of chronic kidney disease between 20 to 43 years is 1.3 times higher in the preterm cohort. So now I've told you about the risk of chronic disease following preterm birth with a specific emphasis on cardiovascular disease risk factor and cardiovascular disease itself. But what about risk and protective factors, which is something important to know so we can potentially act upon it? So in terms of hypertension, as I said, in terms of the perinatal risk factors, preeclampsia as a risk factor, and gestational diabetes, which puts a high importance of the health of the mothers. But on the good side, breast milk has been shown to improve cardiac phenotype. So it's really important, once again, to promote breastfeeding in mothers or just intake of breast milk in general. In terms of risk factors and protective factors in infancy and childhood, what we show is one of the things in follow-up in terms of nutrition for children, especially which are small, we always are worried that if there's too much catch-up weight gain, this might be a problem over the long term. But what has been shown is that there is no association between catch-up weight gain up to 18 months corrected age and blood pressure. So in short, children who will catch up in weight gain between 0 to 18 months of corrected age will not necessarily have higher risk of blood pressure. However, after 18 months of corrected age, if there is excessive weight gain after that, the risk of hypertension increase. And for children who don't have a high BMI, so for those with a BMI below the 85th percentile, poverty is also associated with higher risk of hypertension. What are the mechanisms behind that? Is it because people who will live in poor condition have less access to healthcare or exposed to other conditions which can have an effect on blood pressure? That might be possibilities, but have not been well explained in studies so far. How about glucose intolerance? Well, we know that children who are not just born preterm, but also with lower birth weight, have a higher susceptibility for glucose intolerance. And once again, excessive weight gain after 18 months of corrected age will be associated with higher risk of glucose intolerance. And conversely, lower lean body mass, so lower muscle mass, will be associated with more glucose intolerance. Finally, if we look at respiratory health, what's a little bit discouraging is changes in respiratory care in the NICU have not been associated with better pulmonary outcomes. So in these studies, they've looked at whether moving to more gentle ventilation was associated with better pulmonary outcomes. So far, this has not been identified. There are some suggestions that there is an accelerated decline in pulmonary function among patients with BPD who are exposed to cigarette smoking. And this is, I'm showing it in the red line, which shows that if you're smoking, maybe not only you'll have a decrease in the lung function, which is expected, but this might be accelerated. Other studies have also found that if there are signs of inflammation on chest CT, this may be associated with worse respiratory health. Although this is more in a study setting, we would not do a CT scan to look for inflammatory signs on the lung. So what can we do to improve outcomes? And I like to think about it using a life course approach. Because if we think about it, you have the baby who's born preterm, who becomes a young child, and then after a teenager, and eventually an adult. And this adult will become a parent who will in turn be pregnant again and have a baby. And I've already told you that babies who are born preterm may have more hypertension, and we know that hypertension, and I'm just using hypertension as an example, mothers who have hypertension are at higher risk of delivering prematurely. So there's a kind of a loop. So it's really important to see how we can break the cycle at any step to improve health, not only of the adults, but also of the future generation. So I like to think about it as a timeline. So you have the parental health, then you have pregnancy and the intrauterine environment, then you have preterm birth and the neonatology stay, and then you have the period from infancy throughout adulthood. And the goals will be different at each step. Obviously, if we can reduce preterm birth, that would be amazing. And I guess I will leave that to the obstetrician and also the scientists who can understand better the mechanism of preterm birth. But at the same time, we know that some of the risk factors for preterm birth are associated with the parental health. So really, as healthcare provider, we can make sure that the parents will be as healthy as possible. Then during pregnancy and preterm birth, the goal is really to optimize organ development of the preterm baby. In the NICU, we really want to avoid organ injury. And afterwards, we really want to avoid any secondary hits or that could lead to accelerated decline in the organ function. And I'm thinking about obesity, for example, or smoking. So what can be done as intervention? So as I've mentioned, really it's to optimize pregnancy care and maternal health. And I should say parental health in general, because more and more we can see that also paternal health will significantly affect the health of their child. So that means better access to antenatal care to reduce preeclampsia and gestational diabetes, smoking cessation that should start as soon as possible. Because we know that children will become parents later on, we want to reduce childhood and adult obesity and really encourage optimal maternal nutrition. What can be done in the NICU? It's really any care to support healthy organ development. And it's hard because sometimes the intervention that we do are important to support the health of the baby and the survival, but really want to avoid inflammation and oxidative stress. For example, try to avoid anything that would favor sepsis, try to avoid hyperoxia. If there's a choice to avoid nephrotoxic exposure, that's also important. As I said, support optimal nutrition and breast milk. And maybe there's room for future therapies to decrease things like bronchopulmonary dysplasia. And as a pediatrician who is doing long-term follow-up, what we can do is really to avoid over, under malnutrition, avoid respiratory infection, and that goes through immunization and infectious disease prevention. Avoid nephrotoxic exposure, something like ibuprofen maybe should not be favored when it's not necessary. And once again, this is not very original, but it is so important, and even more so in the preterm population, but promote healthy lifestyle habits, which means avoid tobacco smoke exposure, and monitor and treat for hypertension and diabetes. So that requires that the child is actually being followed, and in adulthood also have regular checkups to screen for risk factors, which all have interventions that can be done. And that brings me to this point that preterm birth is not yet identified as a condition for targeted cardiovascular risk screening. And it's very interesting because I've looked at North American scientific statement for risk factor of cardiovascular health and cardiovascular risk reduction. I've also looked at guidelines for prevention of hypertensive disorders of pregnancy. And this is, for example, the guidelines from the Canadian Society of Obstetric and Gynecology, and it talks about the risk factors for preeclampsia and which woman we should screen for and really offer more closer follow-up. And preterm birth is not part of these risk factors. And it's the same for cardiovascular disease. When we look at these guidelines, they will talk about obesity, the child who had chemotherapy for leukemia, for example, who might have higher risk of cardiovascular disease. But preterm birth is not yet identified as a risk factor, which means that family physicians or nurse practitioner will not really think about monitoring the blood pressure or the glucose of adults born preterm, which may lead to missed opportunity to intervene early and improve health. So in conclusions, preterm birth occurs during a critical period of organ development. And I've shown that preterm birth is associated with an increased risk of chronic health disease, such as hypertension, diabetes. I've touched a little bit about osteoporosis and chronic obstructive pulmonary disease. However, I really think that using a life course approach, we are all well positioned as healthcare providers, from obstetrics to the NICU and pediatrics and even family medicine later on, to change positively the health trajectory of individuals born preterm. That means better access to healthcare, better awareness for enhanced health monitoring of preterm populations, and the earlier identification of risk factors to prevent and intervene earlier. And I'm just showing here a picture of some of the participants in our study who've been so dedicated. And I'd also like to acknowledge the work of my research team. You have in red here, it's Dr. Anne-Monique Thuy, who's an amazing neonatologist here in Montreal, Canada, and some of my students and research associates. And I'll be pleased to take some questions from here.
Дякую дуже. По-перше, перше питання від мене. Які є найголовніші takeaways з цього дослідження? Наприклад, я почула про ще один фактор, про важливість грудного молока для цих дітей. Так? Що ще? Ось є такі великі takeaways цього дослідження. Як ви думаєте?
Yeah, so I think it's not very original, but we know about the healthy lifestyle habits and we tend to forget it. Very often we're very attracted by very expensive technologies, but we forget about preventative care and promoting healthy lifestyle habits with, like, smoking cessation, promoting physical activity, healthy nutrition. So I think this is one way really to prevent health and to prevent disease. And I think it's important for everybody, but even more so, I think, in the preterm population, which is at higher risk of chronic conditions.
Тоді далі теж спитаю про канадську мережу спостереження за новонародженими. Наразі, чим ви задоволені, що вам вдається, а що б вам ще хотілося?
What's very nice with the Canadian Neonatal Follow-up Network is that it's a network of all the 26 clinic teams across Canada. And so what it has helped us is really to harmonize practice and make sure that we were doing similar things. So all Canadian preterm babies, regardless of where they are located in Canada, had similar high quality healthcare follow-up. So that was one of the really good things, is really to share our practice and to improve and offer the same type of care. What we're trying to improve now, so what we've done so far is really to harmonize the 18 to 24-month follow-up, where we really look at all aspects of neurodevelopment. What we're trying to improve now is our capacity to identify cerebral palsy earlier. So we're trying to implement best practices for earlier diagnosis of cerebral palsy through implementation of the Hammersmith infant neuro exam and the GMA. So this is one of the things which is nice to do as a network, is teams will be sharing how they have been able to do the HIND, so it can help other teams. So it's really this collaborative effort. And the other thing is we are collecting data for all of Canada. So it really allows us to monitor what's happening in the NICU, because we're seeing the babies at 24 months across Canada. We're collecting data. That's a way to make sure that the treatments that we're doing in neonatology don't have any adverse outcomes, or if they have good outcomes, that we're able to show it.
І в мене ще декілька питань стосовно того, що ви зараз сказали. Ви сказали, що є мережа і всі спілкуються з усіма, і це допомогло, якщо я правильно зрозуміла, деякі речі стандартизувати по тому, як надається допомога новонародженим. Чи ви можете привести якісь приклади, що саме було в фокусі уваги, що вдалося зробити однаковим для всіх?
So one of the things we've standardized, it was really at first directed for data collection for research. The reason was that collecting data over the long term is so important to monitor practices in the NICU and for quality improvement. So for example, if we find that for 1 year there's more hearing impairment that we see, we need to understand why, and that's a way to signal it back to the neonatologist. So what we've done was at 24 months to make sure that everybody was doing the same, meaning collecting the same data on vision function, on hearing function, having a standardized neurological exam. And what we've harmonized is everybody to be doing a developmental assessment using the baby scale. So everybody got trained to do the baby scales. So at least everybody was reporting on data, which was the same across the network. At the same time, this reminded everybody of the important things to check at 2 years, at 18 months to 24 months across the network. Now what we found was that 2 years is good, but it's a little bit late in terms of clinical practice. So that's why now we're trying to make sure that everybody is using the Hammersmith and the GMA, during the first 4 to 6 months of corrected age, to be able to pick early signs of cerebral palsy. So this is doing a harmonized 24-month visit with standardized neurodevelopmental assessment has been a first win that we've done over the past 10 years. And now we're really focusing on earlier on, but we also have projects to improve also screening, for example, for developmental coordination disorders. So those are all ongoing projects where we're trying to be better across the network.
Хто входить в мережу і як ця комунікація відбувається? Бо Канада велика країна.
Yeah, so the members of the Canadian Neonatal Follow-up Network are there are a lot of physicians, but also all the healthcare professionals that take care of children born preterm. So we have in our network lots of nurses, we have occupational therapists, physical therapists. We just had like a nutritionist joining, psychologist. So it's really any healthcare professional who will be involved in follow-up. Now, the good things with Zoom or Microsoft Teams is that we're able to reach everybody through webinars. So we have, so in terms of the chief of each follow-up clinic, we have a twice-a-year meeting. We also have a steering committee, executive committee that meets every month and that plan for all these scientific activities. And every year we'll have like one in-person meeting when it's possible that we link with also the neonatologists from the Canadian Neonatal Network. So we try to do once a year in-person meeting, but some people it's difficult to travel. But we have a lot of webinars and activities that happens online. Probably like, every 1 to 2 months we have some activities.
Як фінансується ця мережа і її активності?
So some is funded by research funds. So for example, for the implementing the Hammersmith in all clinics, we got funding from the Canadian Institutes for Health Research, who gave us money to conduct the project. But otherwise, it's really going to be hospital-based, meaning that, for example, me as a physician in neonatal follow-up, I see the babies and I will do the assessment and then I enter the data on a voluntary basis. So when there is no funding, because the infrastructure was already built from previous funding, the teams are more autonomous to do the assessments, and then it's a matter of volunteering to enter the data in the database.
Як ця мережа працює з батьками? Чи працює вона з батьками? Чи це тільки для лікарів?
It's predominantly for doctors, but the projects are built with parents. So we have a close relationship with the Canadian Premature Babies Foundation. So actually for the project on cerebral palsy, it came from a request from parents. So we built that project with parents for earlier diagnosis of cerebral palsy, but not just earlier diagnosis, also how to communicate findings with families in using best standards. And actually when we wrote the protocol to ask for money to the Canadian Institute of Health Research, we did that with families. And now as we're running the project, I have my steering committee with scientists and parents every month, so we advance together. So the network, the members are clinicians, but all the projects are done in collaboration with the Canadian Premature Babies Foundation.
Яке місце неврологів і чи багато неврологів задіяно в цьому фоллоуап спостереженні?
We don't have that many neurologists, but actually we just got one who's more interested, maybe not in preterm babies, but in hypoxic ischemic encephalopathy. So we're starting to work with this pediatric neurologist. But I have to say that the main physicians are pediatrician, neonatologists, and developmental behavioral pediatrician. Neurologists are new, not that we don't welcome them, but they haven't come to us. This is new that we're having them really integrated into the network. But they're always welcome.
Так, зараз перевіряю, чи є в нас ще питання від глядачів. Від глядачів питань немає, але в мене є ще питання від мене. Наскільки зараз популярна професія неонатолога в Канаді? Наскільки лікарі хочуть працювати саме в неонатології з дітьми, які народились передчасно?
I think neonatology is very popular because I think it's the excitement of intensive care with the adrenaline. But is it more popular than other discipline? I'm not sure I can answer that, but there's always, I work in a university hospital with lots of medical students and residents, and neonatology is always popular.
Якщо ви дивитесь на систему в охорони здоров'я, на систему, як організується допомога в лікарнях, чим відрізняється медична сестра, яка працює в неонатальній реанімації від усіх інших? Який профіль такої медичної сестри?
I would say that the nurse who works in neonatology, there's the need of being able to. Okay, so I think in the neonatology it's a lot of acute care. Obviously, you need to take decisions fast. You have to be able to deal with uncertainty, probably more than in other disciplines. So I think the nurse profile, but I'm not a nurse, and I work a little bit in the neonatology, but mostly in follow-up. I think the nurse I meet, they're usually able to take decision fast, able to deal with uncertainty, and I think you have to be able to deal with the stress of having unstable babies all the time, compared to, for example, a nurse who work in child development where things are moving much slower.
Є питання від глядачів. Яка головна скринінгова шкала оцінки розвитку у їх системі спостереження, окрім Хаммерсміт?
So I would say that after 2 years of age, so we're doing the Bailey scales at 2 years of age, but that's more an assessment that requires some training. We'll then advocate for the ages and stage questionnaire, the ASQ, although we have to acknowledge that it's not perfect in terms of sensitivity and specificity. So usually people will use the ASQ as a framework to look for red flags for abnormal or atypical development, but knowing that it has to be taken within the whole history of the patient and also observation in clinic.
Зараз перевіряю, чи є в нас ще. Так, є подяка є доволі багато подяки від глядачів. І хочу ще спитати наприкінець, бо ми майже 1 годину вже є в цьому ефірі. Розкажіть якусь пацієнтську історію, яка вас вразила.
Yes, I can certainly do that. So actually in the study, in our study of adults born preterm, so the HAPPY study, so we did recruit, adults who were born back in the 1990s. And so we sent letters to families and people would respond. And there was this girl, Camille, who participated in the study. And she was so fascinated by the study that she reached to us to see if she could work in our research team. So she actually did a master's degree, loved it so much that she went on to do a PhD. And afterwards, she decided to become a doctor, and I can tell you that she just graduated from med school recently. What's very amazing is Camille is now, in her late 20s, but she was born at 26 weeks. The doctor said she was not supposed to survive, and here you are with this beautiful young lady who is now a doctor and PhD. So I think that was very touching to see her participate, but then also grow as a scientist. And her goal now is actually to work in public health. to increase awareness about how preterm birth can affect long-term health and make sure that we have a better healthcare system for adults born preterm. So I think it's a beautiful story from a little baby who was not supposed to survive 30 years ago.
Я дуже вам дякую за цей ефір і дуже дякую за цю красиву історію, надихаючу. І всім дякуємо, хто нас дивився.
It's my pleasure. Thank you for the invitation.